Good afternoon. My name is Dr. Karen Hurley. So just to tell you a little bit about myself, I'm a clinical psychologist by training, and I have specialized in cancer and hereditary cancer risk for over 20 years. I'm currently at the Cleveland Clinic. I have, over the course of my career, earlier I was more emphasizing research. Now I am mostly a psychotherapist who sees people who are dealing with all of the different things that cancer and hereditary cancer can put on your plate. So what you're going to hear today is a mix of results from the research literature, but much more so my experience of sitting in the room with many, many people as they have worked their way through the challenges of cancer and sharing the accumulated knowledge that we have generated together in the room. So I would like to dedicate this talk to all of the people who've placed their trust in me, whether it was in a therapy room or maybe they asked a question when I was giving a talk, and that connection we have made in the past is represented in what I will be talking about today. Just so that you know, I don't have any conflicts of interest to disclose, and any photo of a person that you see does not represent an actual patient. So first I want to talk about how much this talk is different than it would have been 5 years ago, 10 years ago, or when I was first starting out. Back in the day, a talk to a group of people who were cancer patients and cancer survivors might be pitched differently than to people who were living with hereditary cancer risk or from families where risk of ovarian cancer was being passed down. Now those two worlds overlap to a much greater extent. If you look at the current guidelines from NCCN, who put out recommendations for genetic testing, you can see that genetic testing is recommended for anyone who's been diagnosed with epithelial ovarian cancer. That is the most common kind of ovarian cancer to develop. And that's at any age, not just an early onset ovarian cancer. And furthermore, for people who don't have ovarian cancer themselves, but they have a relative who would be you, it would be a first or a second degree relative. And so what does that actually mean in terms of families and family communication? A first degree relative would be a parent, a child, or a sibling. So when I was first starting in graduate school and we were talking about families living with ovarian cancer and ovarian cancer risk, we focused on the first degree relatives. And as you can see, this would be a very sort of intimate family experience. Now, with second degree relatives included, there are a lot of more people who have a stake in whether your cancer is the result of an inherited mutation. Grandparents, aunts, uncles, grandchildren, nieces, nephews, and half siblings. So what that means is a couple of things. Number one, not everybody in this group may get along with each other, or you may have difficult relationships with some of them. Whole branches of the family may not be in contact with each other for different reasons. And then so what that does is introduce multiple opportunities either for conflict or miscommunication. Another thing that can happen is that risk information based on the cancer that you are currently going through introduces some invisible lines, and that cut in a couple of different ways. So first of all, if there are branches of the family who are not in contact, it can draw a line connecting you to people who you may not have even had contact with in a long time. I have a couple of patients who are dealing with, they both happen to have a BRCA mutation that they inherited from a father that they had never met. And so that becomes an invisible line that connects them. On the other hand, if you have a blended family, for example, maybe it's a second relationship for you and your partner, you've brought some children together. Now imagine a scenario where you have two young adult daughters. Maybe they're both in college, one from each prior relationship. And you've been working very hard to create a sense of family and siblingship, but then only one of them will be at risk for the mutation that you may carry, and that puts an invisible line between them. Another thing that has happened over the years, that as we do more and more research about ovarian cancer, we've learned that it is part of several different syndromes. I first came to learn about hereditary cancer risk when the BRCA 1 and 2 mutations were being identified and clinical testing was being developed. We now know that ovarian cancer is part of other syndromes that are associated with other kinds of cancer. For example, some of you may be here who have Lynch syndrome, where the risk of cancer includes not only ovarian cancer, but endometrial or colorectal cancer. And so this puts a lot of extra things on your plate in terms of decisions, appointments, or concerns that you may have about your own health, but it also puts it on other people. So imagine you're telling one of your second-degree relatives that they need to consider genetic counseling and testing, and they go and they're being talked to not about ovarian cancer risk, but colon cancer risk, and that they need to go have a colonoscopy. That may not make sense to people. So you can see that this complicates the task of communicating about risk in families. And, if you're currently facing a new diagnosis or in treatment at a time when there's a lot going on and emotions are running high. So one thing that you can do to start to sort through some of this is to think in terms of developing an information plan, that the information about risk that your diagnosis now puts in the family space is not only finding good sources for your own genetic testing and what you might be recommended to do for your own health. At the same time, if you're currently going through a cancer diagnosis and treatment, and you may choose that you're not ready for getting genetic testing, or that it may not be informative for you. However, your results would be informative for other people. So, for example, your granddaughter may decide to go get tested for ovarian cancer risk, but if she doesn't know what your result is and she's negative, she won't know, is that because there's a mutation in the family and she doesn't have it, or whether the cause of ovarian cancer that you're living with is unknown. Therefore, involving genetic counselors at this stage to learn about options for things like maybe you want to be tested and have your information available for others, or you may want to explore options for banking your DNA so that it can be tested at a future point to be informative for someone else's risk. Another complication is some families can be very spread out. So you may have your oncologist, physician, and genetic counselor that you've been working with, but a relative who is interested in testing may not be able to consult with the same professionals. So in that case, being able to plan where are they going to go? How do they access good quality information? Now, with all of this complexity, traditionally genetic counseling would work with, you would get a counseling session before you got testing and then have another one afterwards where you would discuss some of this. Now the landscape is more varied. So the way I look at it is there's never a bad time to ask for a consult with a genetic counselor just to talk about things like your information plan. And the last thing that I'll say on this is that it's also okay to appoint who I call the chief information officer in the family. If you want to be focusing on your medical treatment, you can ask someone else to be the one to disseminate some of this risk information. So let's talk a little bit about living with ovarian cancer itself and what are some of the stresses that it puts on families so that we can talk a little about how to talk about that. So first of all, cancer is unpredictable and it does not color inside the lines. So we see situations where people can get it quite young or, in advanced age. We can see it develop in people who are very fit and eat healthy. How was it that I did everything right and I got cancer anyway? This is a scenario we see fairly often. So you may be going through thoughts like that yourself, but other people may also be asking that. And that level of uncertainty is a breeding ground for anxiety, which then affects family communication. Another thing, and again, this has to do with the overlap with genetics, is that genetic risk is random. So if there is mutation in the family, most often it's one that confers a 50-50 chance of passing it on. And at least as far as science knows, there's nothing that can explain who gets it and who doesn't. Now, you may have either spiritual or religious beliefs that have a different perspective, or you simply may feel like this goes against the idea of the universe being fair, that, if you're a good person, why is this happening to you? So this can be very challenging to think about the idea that something so important to your health or to the health of people you care about is up to chance. Another thing that we see is that sometimes people will be surprised at how stressed out they get by going through cancer. If you think of yourself as a resilient or a strong coper or someone who's very decisive and that you have good coping resources, what can happen is, say you're someone who likes to exercise and that's a source of stress relief for you. But you now find yourself going to many more appointments, not feeling as well, lots of disruptions at work and at home. And so what happens is that some of your coping resources are now off the table because of your health while your stress level is going up. And you can see this gap that opens up between the two. I call this the coping gap. This happens for people who are going through illness, and it also happens for their caregivers. So let's talk a little bit more about caregivers who are likely family members or people living at home with you. First of all, cancer has a way of kind of upsetting family routines and putting people in the position of having to do tasks that are unfamiliar to them, whether it's, having to take over the children's activity schedule or being the one to cook meals. If this is not something that you normally do, it can feel challenging to not be doing stuff that you feel good at. It can certainly add a lot of extra tasks that you have to do on top of things that are already your responsibilities. Another thing that can happen is expectations that are based either on ongoing family dynamics. Sometimes these can relate to gender. So if you have some family tasks are associated with being one gender or the other, and then you have to do the opposite one, that can create an additional sense of kind of friction and unfamiliarity. It adds another level to that. One thing that we do know from stress and coping literature in general, not just from cancer, is that hassles are strong drivers of mood. So all of the extra hassles and tasks and people trying to do things that they're not used to doing can lead pretty quickly to anxiety and depression in a way that makes people feel not themselves. They feel a little wrong-footed, that, they feel like, they should be more resilient than they're turning out to be. So that's normal, but it also means that one way to help the family and help communication is to look for ways to reduce hassles, to streamline things. I call that, if there's anything you can do to make your routine a little more aerodynamic, just things that you don't have to think about or decide, that can kind of bring the distress level back down. Now, with caregivers in particular, there's a phenomenon, I call this the resilience pedestal, that people think that you're going to always be strong, always be positive, and to keep going, and that's the face that you want to present to the world. However, we know that that is not realistic. People have all kinds of feelings, and sometimes you might feel tired or discouraged. Another thing that is true is that you can't always keep going. People do need respite, and that's especially true as treatment goes from the crisis phase into a longer chronic phase. So one example I use is, those auto races like the Indy 500, where they're going round and round and round. No car, no driver can finish that race without stopping at least once. Even if they don't want to, they have to pick a point to pull over and recharge. And caregivers are very much in that same position. I want to give a special comment to fatigue and communicating about fatigue, because that's such a common feature in cancer and going through cancer treatment. One thing that's really important to communicate to other people and that they will hopefully get, and some people are more educable than others about this, is that fatigue is different from tired. If you say, wow, I'm so wiped out from my cancer, you might get a response like, oh, hey, me too, I'm really tired. It's not the same thing. So with fatigue that is medically related, it can come on fairly suddenly, and then there's a steep crash. Once you've hit that crash point, if you hadn't had a chance to get some rest before then, it can take longer to recover from a crash. And it's also somewhat unpredictable from day to day how you're going to feel. It's pretty predictable that you'll have fatigue, a couple days after chemotherapy infusion, but there may be other times where it just comes on all of a sudden. That can make it really difficult to do things like make plans with other people. And then some people will be better than others about dealing with the change in plan or disappointment if you have fatigue and can't follow through with a plan. So one thing I talk to people about regarding fatigue is, I call this the 3 shelves technique, is that you keep sort of a mental list of activities that you could potentially do based on your energy level. So you have your high energy self when your vitality is the best, and that's the shelf that you draw from, like, hey, we could go for a walk today. The middle shelf would be something that takes somewhat less energy. And then the low shelf is having a couple of activities that you do with pretty minimal effort or concentration. Titrating up and down from day to day and pulling from your activities from the shelf that match your actual energy level, not the energy level you think you should have, but the one that you're actually experiencing, can help with your stress level. But you can also use this to communicate with people. So, for example, if you want to make a plan to get together with an old friend, you can say, if it turns out to be a good day, here's our high shelf activity. We'll go for a walk together. And if it turns out to be a low energy day, maybe we're going to sit on the porch together and enjoy the sunshine. So if you prep someone ahead of time with the idea that the plan, having a high and low shelf options ahead of time can help smooth out some of that communication. Lastly, and this is another thing that can be hard to convey to other people, is that when we're going through something like cancer diagnosis, is that it's a strong stressor and it may resonate or echo with past stressful experiences that you've been, even if they have nothing to do with cancer. It's more like the emotional intensity from back then matches the emotional intensity now, and creates this resonance that can actually amplify it. So that can be with past experiences or with current stressors. But what that means is that people may not understand, or you may not yourself understand, why are you feeling so sad about this? It may be in part because it's taking you back in time to another time when you were going through something hard, and that's been reactivated in your life. So now let's talk a little more about family dynamics, because of course, some of those echoes that you may be experiencing may be things that you went through with people in your own family. So one of the ways that I talk about a cancer diagnosis is that it's like the earthquake that shakes the building. So anything that is strong will stay standing, but anything that's already got a crack in it or is not well supported may fall over. That applies to coping strategies, also applies to relationships. So if there are already tensions between you, those may become more prominent under the stress of a cancer diagnosis. Truth be told, I can't remember whether this, where I saw this expression, but it resonated with me very strongly, is that one of the sources of stress and strain, or one of those fault lines that may be there in a family, is what we call the crucible of autonomy. We all learn how to be autonomous people in the course of our physical development. We learn to pee and poop independently. We learn to walk, and we are supported in that and encouraged, or experience other kinds of reactions in the context of family in developing that sense of autonomy and independence. And we each learn in our own ways based on the family culture of autonomy and supporting autonomy, how to balance that with the needs of others. So when we're little, our need to explore, maybe to go in the kitchen cupboard and pull out all the pans because that's an interesting thing to do, you eventually learn that other people have a need to have a clean kitchen, and so you can't do that. So that's a small example, but if we bring that up into adult life, it means when you're making decisions about things like what to do about work now that you're sick, or what kind of treatment to pursue, that sense of autonomy may run into the family patterns of communicating about the balance between autonomy and connection. People may have feelings about what it is that you want to do. So just to, again, that idea of the crucible of really crunch time on a sense of personal autonomy is that cancer poses a strong challenge to autonomy. You're going along this way in your life, and boom, cancer comes this way. It knocks your plans off track for the foreseeable future, things that you want to be doing that you had envisioned or hoped for. You can't do things that you normally do. So between those two, you're feeling like your sense of agency has been taken away. And then that also may mean relying on other people. And so all of the family dynamics you have about being able to ask for help or not are going to be exposed, like the way that we were talking about with fault lines. If there's a fault line about how do you ask for help and who gets help within the family, is that may become more so under the stress of a cancer diagnosis. I was working with a gentleman recently who has a cancer diagnosis, and he just had a surgery. He came home, and his wife was rushing to do a lot of things for him. Oh, let me get that for you, because she's a doer and she felt a strong need that she wanted to feel needed, right? And he was getting frustrated because it would take him a long time to do something. Maybe it was a little slower, but he was wanting to feel that sense of agency again. And so we found a way to frame this so that he talked to his wife about his need to recover, not only physically, but to recover his autonomy himself so that she could support him by holding space and giving him that extra time, which meant she had to kind of sit on her hands while he was doing something in twice the amount of time that she would be able to do it for him. So, cancer is so disruptive that it can provoke feelings of anger, rebellion, and sometimes it's not just cancer is not the boss of me, but the way that you might want to start showing that is by doing things yourself or doing things your own way. And people may not recognize how strongly you need that to be true. All right. And that can also create friction. So, in short, you know, as you're feeling more uncomfortable, anxious, or, whatever it is that's going on, people are also having their feelings. So, everyone is more uncomfortable, and people may be having different feelings. But here's the thing is, and this may seem like a radical statement, that each person's feelings are their own job. If you're familiar with 12-step programs, for example, they call that keeping your own side of the street clean, dealing with how you feel, and allowing other people to have their own feelings. So in this case, the fact that you are facing a serious illness may have someone else very worried. And so they want you to do things that relieve their worry. So in that sense, they are making their worry your job, right? That is also a recipe for conflict. So if you start trying to set boundaries about that and, trying to give people their feelings back, boundaries do get pushback. So you may have to say things more than once about saying, no, I prefer to do things this way. This is what I prefer. This is what I'm choosing. And and the task of trying to hold the line on while you're not feeling well, is a challenging one. It's going to be particularly challenging depending on how you've been socialized to think about yourself in relation to others, right? Because you're being asked by your doctors, what do you want to do? What are your feelings? What are your priorities? But if you're used to focusing on other people, this may be hard. That may be just one of your emotional jobs in the family that you grew up with. People who are in caretaking professions where, that's where you spend most of your time thinking about someone else. These would be people like in healthcare professions, teachers, also people who are in rescue or protective occupations. So, for example, people who have served in the military or police or firefighters who are used to putting the safety of others first and putting their feelings to the side while they're very mission focused. They also have a hard time focusing on what do they want and need in treatment. And now this is a particular issue. It comes up more frequently in families where there is hereditary cancer, where multiple people have been affected in multiple generations. So sometimes, say you have someone who was ill as a relatively young adult and has middle or teenaged children who then become the little mom or the little dad and who take on caretaking responsibilities, either for being involved in the care of the parent themselves or taking care of the younger children while the parent is not feeling well. These are both going to create situations where you grow up kind of putting your needs second. And then this is going to create feelings about what does it feel like to receive care or to be in a position of receiving care when you're sick. So again, this is on the theme of fault lines, is that people who are either strong optimists or strong pessimists, if they're in the same household or they're in the same couple, when the stakes are relatively low and, it's about, what are we going to have for dinner? That's one thing. But, in the situation where we're dealing with, very serious considerations, people who are more optimistic and upbeat or who want to stay hopeful can get very frustrated with people who are pessimists, and vice versa, people who feel like they need to worry about what's going to happen or they want to plan for the worst case scenario. You can get friction that way. There's a special case, this is actually a thing, where some people who seem pessimistic, it's not that they're actually downers, but more that they expect the worst with the idea that, if things don't come out so bad, then they're protected, right? Or they can't be surprised by bad news. So it turns out, and research shows this, that if someone has that kind of style where they're defensively pessimistic, that interfering with that style actually can produce more distress than the quote negative mood that, or the negative thoughts that they are putting out. Thinking positive takes on a special connotation when we're talking about cancer, because people will talk about things like the importance of staying positive in order to recover physically, sort of putting a strong emphasis on a mind-body connection to the point that that people may be upset if you seem discouraged or you expressed anger or you express anxiety, that they feel like somehow you're harming yourself, or you may feel that you're harming yourself or somehow affecting your disease process by not being positive. And again, this goes back to the pedestal. If staying positive means that you don't get to acknowledge or validate those feelings or spend time with them, but rather they're rejected, it's more like they're put off in the corner. They don't really go away, but they create a sense of feeling invalidated. When I think about staying positive, I think about giving positive attention to all of the feelings that you have, that if you can hold in a positive light, in a non-judgmental way, that maybe you're having some anger right now, or some grief, or some worry, that that positivity towards the feeling then becomes part of your mood. A couple more things on this point. A lot of people are sensitized to the word should. That if you've ever heard the expression shoulding on yourself, or ways when you tell people what they should be doing, that you're essentially constraining their autonomy. You're taking choice away by telling someone what they should do. And that goes to things that you say to yourself. A second word to watch out for is the word just. People will things like, well, you just need to do X. You just need to take this supplement. You just need to get out of bed. But what that does is it skips over all of what it means to get there, right? So if someone says just to you, it's actually creating a little bit of an empathy rupture, right? Because they're not getting what that's like for you. And that can also create friction. That sense of couldn't you just takes on an extra poignancy when it occurs in the context of long-term family conflict. So if you've been estranged for someone, or you've had a history of conflict with them, and you think, well, maybe now that I'm sick, maybe they could just put it aside, or can't they just be there for me? That sets up a scenario for a strong sense of disappointment. Again, this is something I stole out of 12-step. There's a slogan that they have called, don't go to the hardware store looking for oranges. If you do that, if you go to somebody that who just doesn't have it to give, that you will experience disappointment. And so you need to be able to be discerning about who is able to offer things like undivided attention, or can go get things for you, or who can focus on what you need to talk about rather than their worries. And most importantly is that just because you need them more now than you ever did doesn't necessarily mean that they are going to change. So now let's move on to another area of family communication, talking with children. And at least in the hereditary cancer space, this is probably one of the most frequent reasons that people seek a consultation with me, is how to talk to the children. So that question, how do I tell them, right? I always say that this has two levels. People come in looking for, what words do I use, right? So that I can explain this to them and so they won't be upset. But there's an emotional level too. How do I go through this? How do I go through the emotionally challenging task of having such a difficult conversation? So we're going to address both of those. First of all, in the situation of threat and challenge of dealing with a cancer diagnosis, it is very natural to want to protect the children. It arouses that fierce need to put them first and to keep them from having harm. In terms of genetic counseling, it's actually one of the most common reasons that people will cite for seeking genetic. It's one of the most common reasons that people will seek genetic testing, is to find out not so much about their own risk, but about their risk to their children. In that context, if there is a mutation or the potential of a mutation passing in the family, parents tend to feel guilty. And, no matter how many times you say to someone, scientifically, it's random, you didn't give this to someone, that guilt, it just doesn't respond. It's actually because we have an emotional need to protect. And so if you tell someone that something is random and you can't protect them, or there's limits to what you can protect your children from, that's very painful. So in some ways, the pain of blaming yourselves and saying and feeling guilty about that may be a little less threatening than the alternative, which is to think that to feel like you're helpless to protect them. So people in that protective mode will sometimes want to protect the children by not telling them what's happening, right? Which may be well meant, but it can actually be isolating for children. And we'll go into that a little bit more. So, or sometimes, for a common scenario is maybe one of the older kids is away at college or is on a trip, and so the parent will delay disclosing and say, "Oh, everything's fine, nothing's going on," when in fact they are, already dealing with a diagnosis and going through treatment. And so what can happen is that when the child eventually does find out, that they can feel betrayed, or they can question, how can I trust that everything's okay if you told me that things were okay and they're actually not. The other thing is that if you hold back from telling children, is that you never know who's going to step forward or who can rise to the occasion. And that includes, children while you're going through treatment. So you may be surprised at the resilience that they do show, or that they're able to generate in a crisis situation. So why tell them about cancer? So the kids, will see that you have more appointments than usual, or they'll see you going through a surgery. They'll see that you're losing your hair, right? They may have already heard about cancer. Maybe they've even heard about genetic testing. Maybe you have a high school senior and they're taking biology and they talked about genetic syndromes in their class, and they may come home with questions. Kids also can sometimes take on emotional jobs that are beyond their abilities. So if they can tell that something's going on, but they're not sure, they may try to be extra good and put pressure on themselves so that they don't stress you out or make you more anxious. And if you don't realize that that's what they're doing, then they're kind of stuck with this feeling of being very anxious. Kids who grow up in that situation can sometimes, as adults, be very anxious or even perfectionists because they're holding themselves to an adult level standard when they're still young. This sense of expectation can also play out in how do you define being a good parent, because sometimes people will feel like their cancer is somehow something that they've done to their child, that they've put stress in their child's lives. And that stems from maybe feeling like, being a good parent means that you keep bad things from happening to them, or you keep them from experiencing feelings that, you would call negative, like feeling worried or sad. Some parents will want to allow their children to be as innocent as long as possible, and that can contribute to either withholding information or that tendency to want to protect them in that way. Now, this image is probably overused in terms of how to deal with children, but I can't think of a better one that gets the point across, which is putting your own oxygen mask on before helping children. And this very much applies to the task of figuring out how to talk to them about cancer. So what does it mean? It means giving yourself some time to acknowledge your own feelings about what's going on, that you do feel guilty or sad, or you feel helpless about the changes that are happening in the family. And these are things that you would not want the kids to have to experience. So making sure that you have at least one adult that you can talk to about these feelings, allow the feelings to pass, and then approach the child in a way that by tending to these feelings first, you then are able to tune in a little more to what's actually going on with the kids and how they're perceiving what's happening. So the next thing I'm going to share with you, this actually comes from the website called Pact Parenting at a Challenging Time. I found them probably almost 20 years ago, and it's still one of the very best resources I've seen for talking to children about cancer. And these are just a couple of their highlights, is that for them, the worst way to hear news is overhear it. Kids have little antennae. They can tell that adults are upset. They can tell that all the adults stop talking when they come into the room. And so if they don't know what's going on, they may be making things up in their heads that are worse than what's actually happening. Now, especially with older kids, is that they may have already started to put some of the pieces together even before you approach them to talk about what's happening. So you may want to start out by listening or asking. You may have noticed I've been going to the doctor more often. Have you had thoughts about that? And then building from there. We want to be sure to use age-appropriate language, but if you use euphemisms, that can lead you into issues. For example, this is a boo-boo. This is not a boo-boo. But if you say, I have a boo-boo in my belly, or I have a boo-boo in my breast, and that's, I'm going to get that checked, a young child may find that confusing and think that they have to go to the doctor for a boo-boo. Sometimes you'll get really prepared to have a big talk with the kids, and they'll kind of look at you for a moment and then say, can I go play my video game? So kids process things in different ways and on different timetables. And so they may need to go back to their routine and act like everything is just as it is for a while before they are ready to start asking questions. So a good thing that you can do is to see communication as a process, not a one-time event. If you have ways of spending time with your child where you're not sitting them down on the couch to have a serious conversation, but you're doing something else, maybe you're driving them somewhere and you're both looking ahead rather than at each other, that might be the time when they start to pop up with questions about what's happening. And this is someplace where people can really help you out. Other adults can step in is while you're going through treatment or going through a lot of appointments, is to help the kids maintain their routines as much as possible, regular meals and sleep, getting to school, that it's okay to keep up with their hobbies or their activities and to keep contact with their peers while other things are going on. And that you can help structure their contribution to the family. So, for example, if you can give them tasks that are doable, that are age appropriate, that way they feel a sense of competence and like they're connected to what's going on, but not overwhelmed. It's still the adults who are in charge. So as you're preparing to have the conversation, you want to think about not only your child's age, but their maturity level, which may or may not be the same. If you have a spread in age of children or they have very different issues, you may consider whether you tell them all together or you tell them separately. And you want to really think about what are your kids' tells? When they're upset, are they more the type who get tummy aches? Do they withdraw? Do they start regressing and they forget how to do things that they already know how to do? So that way you can keep an eye on how they're doing. So, as we move towards closing, I want to say a little bit for folks at the conference who may be living with stage 4 disease, in the sense that everything that we've talked about so far still applies, but there can be a lot of emotions associated in that gear shift in treatment that moves to a more chronic phase. Um, you're going to be asked to make decisions about your treatment preferences, and people may have strong opinions about what it is that they think you should be doing. And so clearing out enough time for you to be able to focus on yourself, to think about what's important to you now. What do you want to be doing? How do you want to be spending your time? When you have a good energy day, what is important for you to focus on? One thing that's hard to get across to people is that you get more isolated during treatment because, either you're spending time in an infusion chair or you're in bed recovering, but that doesn't count as solitude. That's an enforced isolation, but you may also need some of your higher energy time for reflection. You may need that as time to yourself. So understanding that those two needs are somewhat different can help convey that to other people so they don't misunderstand, why you might be withdrawing even though you're having sort of a good energy day. Um, Sometimes people may not agree with your priorities. And again, this can have to do with people's feelings about prognosis, right? We know now that with chemotherapy regimens, even in stage 4, people can spend quite a bit of time at that disease stage. And so you may be, thinking, how do you want to spend the next bit of time? But you may not be thinking about where is this going. You may not be thinking about an end or mortality. Whereas for other people, they may want to start talking about that right up front, right? And that's a very individual preference. Other people may call it pessimistic if you're one of those people who wants to think about things like mortality or what happens eventually, and that your relationship to your prognosis and amount of time again may be uh, sort of scary or threatening to people to contemplate. I recently was working with a woman who has ovarian cancer, and she has her first grandchild on the way, and her liver mets are progressing. And so, it looks like she will be able to meet her grandchild, but will not have much time with her past infancy. So we talked about what would you like to do about that? And because she was thinking ahead towards that, she decided to make a grandmother box, right? And so she's put different things in for the child that she imagines she would have shared with her grandchild were she going to be able to be around. And so that's the kind of task that some people may be able to join you in that or to tolerate listening to that, and some people may find that a little much. So allowing people space to have their own feelings and gravitate towards the ones who are able to be present with you with the things that are important to you takes on a different tone at this stage. So in closing, I want to share a couple of thoughts. And this again applies all across the spectrum of disease. And this has to do with the idea of quality of life. So this is something that it's a term we use a lot in healthcare, but it's not just something that we have, and this is one of my favorite quotes about quality of life. It's not just something that we have, a list of important things in our lives, but how to be in that life. The woman in this photograph is someone that I knew when I was living in New York. We were part of a dance community. And she, when I met her, was in the early stages of Huntington's disease. She was just getting symptomatic. And so she had these kind of those characteristic movements that happen as people progress in their disease. And she loved dance so much, and it was her passion. And she wanted to dance for as long as possible. When she was no longer able to walk independently or hold herself up, she at that time, or by that time, had been working with a choreographer who became very interested in the characteristic movements that came with her disease. And they would create performances together. This photo is from their last performance together, where she could no longer stand. So her partner was holding her up as she's got her arms extended and just turning her slowly around on the stage. And this was her dance. This was how she was in her life, right up to close to the end of her disease progression. So, with that, what I want to share with you, and this is kind of the foundation under all of the, what do I say to people about this and that, is the fact that, cancer has come into your life and it's pushed you to think about things that most people do not want to think about. We're all actually subject to random events, not just people who have hereditary cancer in their lives. We're all subject to hard times, and we are all subject to mortality. We say things like, see you tomorrow, but it's sort of common to say, well, you get hit by a bus. It's not so much that, it's really that it's see you tomorrow, asterisk, depending on what happens. But what cancer does is that it makes that asterisk much more vivid and a hard fact in your life, whereas most people kind of blunt or ignore that. So, cancer has this way of may make you feel separate from other people, but it's not so much that it has put something new in your life. It has brought to life something that has been there all along and that we do all face sooner or later. So with that, then, given that cancer takes away autonomy, there's a lot that you don't have control over, but there are things that you can communicate to people that are in your power. And that's thinking about your legacy. This applies not only to people who are in stage 4, but this again applies to all of us when we face things like uncertainty or adversity. What do we want to be teaching people? What do we want to represent? What do we want to pass on about how you deal with these things? How do you deal with the fact that life sometimes puts things on your plate that you have no control over, that you're asked to make decisions that no one would want to make, and you have to deal with feelings that feel, almost too painful to feel. What you learn in yourself, in your personal, individual way of finding your way as you're living with cancer, becomes the gift that you give to your family. So with that, I want to say thank you very much for your kind attention and enjoy the rest of the conference.